Hi, my name is Dr. Jeffrey Sagal. I'm the Associate Medical Director in Baltimore County Fire Department. I want to welcome everyone to the start of this year's Baltimore County Fire Department Emergency Medical Services lecture series. Our first speakers is Dr. Roger Stone and Mario Weber. Dr. Stone is a lifelong Marylander. He grew up in Bethesda, graduated in high school with a bilingual education, French as an aside, and attended the University of Maryland at College Park. He moved to Carroll County, where he was an EMT for 12 years. He obtained his MD at the University of Maryland in Baltimore in '87 and did a residency in emergency medicine at the Medical Center of Delaware and Christiana. He was a community physician at Carroll Hospital Center, at which time he created and remains the Associate Medical Director in Carroll County Fire Department. He returned to the University of Maryland, Baltimore County in '96 to finish a master's thesis in emergency health services and as their first EMS fellow. He's had numerous activities. He was subsequently served as the medical director for Carroll County EMS. And then in 2001, he began the start of his tenure up to 24 years now in Montgomery County Fire and Rescue. Dr. Stone has been involved in all sorts of projects and research for the improvement of emergency medical services throughout the state of Maryland and continues to till this day. Additionally, we have Mario Weber, who received dual bachelor's in political science and psychology at the University of Florida. He then attended the University of Michigan School of Law. He moved to Maryland and joined the Bethesda Chevy Chase Rescue Squad with Montgomery County Fire and Rescue back in 2005. He served as an attorney in private sector and then circled back for a master's in public administration at American University. All this time, he advanced his volunteer activities at the squad to the paramedic and emergency medical service officer. He worked as a career paramedic and field training officer for Alexandria Fire Department in Virginia, where he focused on quality management, advanced training, and evidence-based protocols. He is a volunteer ALS representative for the Montgomery County Medical Review Committee, where he applies his expertise and is instrumental in developing clinical decision support for ALS and BLS downgrades. He presents data relevant to the implementation of the National Association of EMS Physicians Scientific Assembly. He now serves as a senior advisor and field leadership director for FEMA in Washington, D.C. I want to welcome both of you here and thank you for joining us and starting this semester's. So I'll now turn it over to Roger and Mario. Welcome.
Thank you so much. Thanks so much, Jeff, for all those kind words. Both of us are very honored. It's nothing less than an honor to be with you all virtually this evening. I'd love nothing less than to actually be with all of you in person if I could. But this new technology that's kind of exploded in the last half decade has a lot of advantages in terms of getting lots of people together, no matter where they might be, minus the commute, to discuss ideas, best practices, and learn from each other. And that's really the spirit of why I'm here. I also wanted to start out by tipping my hat to the institution that is the Baltimore County Training Academy Thursday night lecture series as an iconic, in my view, Maryland educational institution founded by one of the most, or at least co-founded by one of the most respected EMS clinicians and physicians in, I would say, our state's history, especially in the educational realm. And I'm talking with the deepest humility about our cherishing Dr. Barinholtz's memory as we get a chance to address you all this evening. Yeah. And a quick shout out to Jeff. I've known Jeff for quite a while, and he's occupied a limited space in the state of one of our boarded EMS physicians with a background specialty in anesthesia. Dr. Barinholtz was critical care anesthesia, people like Sam Galvano. And so that's a small respected states of critical care and anesthesia clinicians who've basically put their foot in the EMS space and gone on to really contribute, especially in educational and medical oversight realms in the state. He reached out to me a few months back and I said, what an honor, it's overdue, because I've known about this, the Thursday night lecture series, and I can't tell you how thrilled I am. And I have to say something about how great it is to share the speaker stage tonight with one of our combination services most engaged and thoughtful and modest yet scholarly members of the volunteer side of our ALS constituency, who's been really instrumental in the areas of safety, human factors in practice, peer review, remedial education, and oh, by the way, as solid a street medic as you'd ever want taking care of your friends or family. I certainly would trust him, knock on wood, trust him if he had to come take care of one of my loved ones. And the rest of the names on this first slide are people who I have to mention as foundational supporters of the quality improvement tenets that we'll be describing during the talk, with others even since the folks on this slide who have sort of taken the mantra in our QA shop and QA quality management shop, Tony Scott, others, Ben Kaufman, et cetera. They're just great to work with. And I carry a little piece of them here with me tonight because without them, I couldn't be talking to you. Before getting started, Mary and I are deeply aware of one other thing about tonight. We're moved about the scheduling of the series, not only as the first to get us started after the summer, but the scheduling of the series on the 24th anniversary of one of our nation's most profound tragedies. Indescribably painful and gut-wrenching as it was, especially for our brothers and sisters in public safety and public health. It also unmasks the unparalleled greatness that is this American story and selfless dedication of our uniformed citizens in all aspects of public service. So I would propose for that, in honor of that, that we pause for a few seconds of silence in honor of all their sacrifices, not only 24 years ago, but throughout our country's history. Please join me. Thank you so much. So first of all, looking at this slide, I believe the lion's share of the audience from Maryland probably knows where we are, in the country. But when we talk about Montgomery County, Maryland, but just in case we're joined by some folks who are remote to our region of the state or not from the state, we're one of the two jurisdictions that abuts from the north and of the Potomac River, the District of Columbia, as you can see on this map. And we are the largest EMS operational program in Maryland by population. We serve about 1,050,000 residents and plus or minus 100,000 visitors and workers daily as they come in and out of the county. There's a lot of vulnerability of the different things that require public safety in a county our size. We're dispatched to about 143 to 145,000 calls a year, about 115,000 of which are EMS in nature, resulting in about 77,000 hospital transports yearly, and a call volume that I might add is growing faster than the rate of the population itself, which, by the way, is not different than other places. The call volume up and up and up, even as the population fluctuates more modestly, right? We run from about 35 firehouses and 2 independent rescue squads. I would add that they are iconic. Not only the Bethesda Chevy Chase Rescue Squad, where I grew up, helping my mom donate after they gave us the pamphlets in the 1970s. And a lot of people who know about Wheaton and volunteer rescue, they say there's no beating Wheaton. So for those people who might be in the audience from Wheaton, we're giving you a shout out there. So today we're going to talk about the county's now mature ALS to BLS downgrade process. I'll talk about some of the data that led us to focus on downgrade issues and classify some of the risks and pitfalls that come from an ad hoc or uninformed way of making decisions. For lack of a better word, when you wing it, that's probably not the best thing to do. And we're going to talk about what we thought was the best way of conducting that process. Then Mario is going to talk about the program itself, how we validated a tool to guide our decisions. We created a 3-pronged process, codified it and piloted it, and I'll circle back with some data on the results of our interventions in a quality improvement to try to affect process compliance. And then we'll include in our discussion some common pitfalls about downgrade decision making, illustrated through 2 or 3 of our type of cases where we could encounter these types of patients, daily, monthly, yearly in the county, right? But the overarching objective here is sharing just our one example of practice with colleagues so they can evaluate their own processes involved in downgrade and make some decisions, maybe with some ideas from elsewhere on how to conduct this type of quality intervention in ways that suits their local needs. We also want to let you know that we're absolutely not telling you how to actually comply with your local protocols. We have some local issues in Montgomery County that sort of drove the way that we're going to describe. So there's our objectives. So I talked about what we can encounter. So let's start with a case, and I'll start out with the basics of it, and then we'll move to dispositions later in the talk so that you can make a connection between the outcome and what we've been talking about. So suppose you have a BLS ambulance and an engine as a first responder with a medic coming from elsewhere. It's a usually healthy guy playing basketball, and when he's over at the bench during a timeout, he feels woozy. He's caught as he starts to wobble and he begins to fall to the ground. They're able to catch him so he doesn't actually suffer a traumatic fall, and they lay them to the ground, and they all, clearly see he's momentarily at least out of it. Something on the order of 30 to 60 seconds, but out of it. 911 is called, and here are some of the first parts of the rubric or the snippet, so to speak. And this is usually a healthy kid, 19 years old, and it's dispatched as a 31 Charlie. If any of you guys are familiar with dispatch processes, maybe you can ask yourself the question, how else might a call like this have possibly been dispatched? And you can put that in the chat box if you'd like. And the second question I asked you is, as presented, would you consider this a high-risk chief complaint? So as we answer that question, for me, this could have been potentially dispatched as a 31 Alpha 3 or a 19 Alpha 1. Now, some of you may not be familiar with MPDS codes, others more familiar, but the alpha determinants are ones that are almost universally dispatched BLS. So this call, depending on what was exactly told to the 911 dispatcher, could go either way. But in this case, the 31 Charlie came out of a description of, is he breathing normally? Well, he's kind of breathing fast and panting, and it was not considered to be normal, and a cautious dispatcher put it out as a single episode in a patient. So how should the crew handle it at the BLS and ALS level? And one question, as I present some of the vital signs here, is should the crew at any level of care be in the mindset of laying the decision at the foot of the patient who's kind of stoic? He's got a basketball game to go to, and use verbiage like, we're happy to take you, but do you want to go to the hospital? Is that kind of a prudent way of approaching that up front? Or could that lead to something where it's more of a suboptimal direction? So does anyone out there think that this could go in a suboptimal direction? Let's hold that thought as we launch a little bit into what we're going to be talking about. And we'll talk about that, as they say, on the other side of the commercial break, a little bit later on in the talk. So I'll frame the conversation by setting out a tenet at the outset, and that this is a discussion that is not at all a value judgment of the process of the concept of downgrading. In fact, the first bullet right on this slide actually summarizes that and codifies that. And we are keenly aware that in some jurisdictions, there's a true necessity for the practice of ALS, BLS downgrades. So that's my little stoneism, that I talked about since the late 2000s. Downgrades are a tool within the privileges to practice as an ALS clinician. And some of you may have heard the old adage, if you've seen one EMS system, you've just seen one of them. So not every system is tiered, but we should start out with a quick description of a tiered system and maybe a couple of its advantages. The goal of a tiered model is actually to assure a quick ALS response to calls that truly wind up being ALS, while efficiently using the transport unit fleet, i.e. the COTS and the BLS clinicians. This type of model allows ALS to hover over a large area where the BLS census vastly outnumbers ALS patients, and it allows each medic to get, if it's used correctly, allows each medic to get more quickly to a larger number of ALS calls over a larger area by returning to service as dictated by the acuity of the patient, presumably after, and this is important, after a thorough assessment. In MCFRS, which, if I say that, it's Montgomery County Fire Rescue Service, we field a base deployment model where the BLS transport capability and a paramedic chase model predominates, which means, for lack of better terms, divorcing the medic from the cot. The basic tenet of doing that is very common across the country, but the paramedic engine model may be different from other systems in Maryland or elsewhere. We see a lot of it out on the West Coast, paramedic engines in Phoenix and other places, but it's unique to some areas. It's not unique across the country, but some areas use it more than others. So our base deployment allows our medics to be divorced from the cot, with the exception of some legacy medic transport units. We use them a lot for our field training, although we also use our paramedic engines and chase cars for field training. And right now we're down to one career chase car with the volunteers putting them in service as often as possible, right? So we allow ALS to return to service when it's the medical right thing to do. And we're not at all averse to that. So why do we focus on downgrades in MoCo? Why did it become a process that's at this point is becoming, a half decade in maturity? Over many months after the transfer of ALS from legacy medic units to these chase models, the numbered cases in the quality assurance shop started to show a trend, and that was that fully 1/5 of all cases where in QA we're trying to make people better. But when we review these cases, fully 1/5 of them had some kind of a nexus to the downgrade decision, right? And so if we look at that over 225 to 300 dispatches a day, which yields about up to 55 downgrades amongst our 25 to 40% ALS dispatches, the problem becomes not so little of a risk in aggregate, right? So if we see a 20% number, the roots of the inappropriate downgrades lie in several places, but ultimately the problem could be a systemic one. And we want to put medics in a position where they can all succeed individually. And it also says, issue number 2, the pitfalls, especially in aggregate, cannot be ignored, and downgrades have to be a priority to address if they're associated with problems with them, right? So for us, this priority is especially self-evident when you think of the number of times we have to use this practice in a day. And in reviewing this cases, the QA shop, and as applicable, the small number of cases that have to go to peer review, you can see that it's only 15 a year, amongst a lot. We would determine that the potential solution had to address the entire system, not just individual clinicians, right? So that's in line with what we call just culture and not blaming the bad apple, and quality improvement as a tenet that we shoot for more than reviewing individual, micromanaging quality assurance. So if we look at the data on the right side of the slide, it shows something that speaks to another point I wanted to make. In purple is the running census of transported patients weekly, and this particular time, starting in 2020 through 2021, shows that bottoming out of the census during the 2020 pandemic and the crawl upwards of the census in the days after the pandemic was waning. But notice that this overlies a percentage of lower, mid, and higher acuity patients meant to be in green, yellow, and red. So while the census was jumping, note that our priority 3 patients clearly hovered somewhere in the 80% range. Now, that doesn't mean that all those priority 3 patients don't have an ALS nexus. It just means that acuity-wise, they weren't crashing in front of us. And this in turn underscores the necessity I referenced earlier of having it out for the medic to return to service when they're not needed. But it all remains a balancing act, right? I remind clinicians of my own axiom, and shout out to my lovely, better half, who reminds me not to be too wordy, which I may be right now, but she talks about stoneisms. And one of the axioms that comes out of a stoneism is you can't affect a patient if you're not with the patient. So when you downgrade, you leave that patient. And the other thing is the patient's needs do not change depending on where the medic is coming from or if the medic is coming at all. The physiological state is what it is. So this same graphic is more, geared towards after 2023 began and goes the last 18 months through July of 2025. And it reemphasizes that while the census here is fluctuating and it's not this uptick after the 2020 pandemic, look at the red, green, and yellow. There again, it remains, close to 80% priority 3 patients, the patients that aren't crashing and can be transported priority 3. Again, not all of that means that they're all BLS, but it certainly remains paramount that I, as a medical director, don't obstruct a tool in the medic's credentials by unreasonably discouraging reasonable downgrades. You don't want to be unreasonable about something reasonable. So when we just need to look at this balancing act and make sure that while we're with the patient, the assessment we do strongly informs this decision making. So now that I took a little bit of time to introduce you to our system and data and our justifications for a quality management approach to safe downgrades, it's fair to ask, well, is this only a Montgomery County thing? And this sort of went into why I thought, hey, could this be a topic I can share with you all, right? But then I asked the question, isn't fair to ask, where else this could be applicable? Certainly, there's a growing part of Maryland that is using the tiered system where the system has to, quote, divorce the medic from the cot. And for those people who know me, one of the things they know me is that I love the state of Maryland. One of those Stoneisms I get heavily made fun of is always talking about from Oakland to Ocean City and every nook and cranny in between. I love the state. I call myself statriotic, and look at the heck of what I'm wearing, right, from my colleagues at the University of Maryland, right? So looking at all things Maryland, I acquired a few pictures from around the state. And for those in the audience, can some of you recognize these 10 pictures from 9 jurisdictions? And what you'll note is that not all of them employ chase cars. Some of them have legacy ALS transport units overlying BLS transport units, places like Anne Arundel County, and they may be getting paramedic engines, and I've talked to John Wendell about that lately, but the concept is slowly spreading around Maryland. Case in point, Howard County paramedic engine that may have been in service for quite some time now. And the last time I was in the main drag in Ocean City, and there are only a couple of main drags, I saw a paramedic engine going up and down the streets of the shore. So this is something that that may be applicable, and that's why I thought I would share it with you. And before I toss it to my colleagues, one last point I wanted to make about ALS downgrades and risk. We mentioned this 20% of QA cases that have a nexus to downgrades. And since MCFRS first started downgrading patients more formally around the turn of the 2010s, our MRC has reviewed inappropriate downgrade cases, right? You would think that maybe they're only the tricky ones, but that's not really true. They can range from this brewing pathology that they're not yet crashing to outright critical presentations that probably we should have caught, and there were clues that allowed us to catch them, right? From undiagnosed STEMIs to patients with potential problems with their airway, right? But amongst the most typical pitfalls are those that center on the knowledge gap of foresight surrounding this natural history of disease. You get a patient, you get clues, and you don't necessarily take the time to have foresight of what may herald deterioration, right? And those patients may not start out necessarily ALS looking, but ALS work still needs to be done to assess them so you then can later treat them. So at the same time as this advantage of the tiered system, the department recognized that each little downgrade may provide an opportunity for error, so the aggregate practice in a county like ours creates cumulative risk. And what we did is we used this consciousness level to try and classify what this risk is. And it comes in 3 major areas. Obviously, paramount is the risk to patients. Ultimately, this is analogous with the risk of physicians underdiagnosing or overdiagnosing, undertreating, overtreating based on their working diagnosis. And so patient outcomes are at risk here. For clinicians, primarily it's logistic and medical tolls of errors. Some have psychological tolls when they know they did something that they wish they could have back. And then medical legal consequences. And I feel for every medic that ever has to find themselves in a court, right? And obviously, medics don't like to have to be retrained if they could have just taken some of the training they had in the beginning and apply those tenets, right? So ultimately, there's also risk to the system because the system, if you've ever heard of the Latin term respondeat superior, that simply is one that says that if you work for someone, the master is responsible for you. So this holds the municipality responsible for the omission or the commission of its clinicians. So it does behoove the county to be aware of that. So in our line of work, we know that we can't control all patient outcomes and all risk, but we can manage downgrade risk like many other risks we face on the suppression side, because many of us are dual role all hazard. We like to call ourselves an EMS, based fire system for the EMS guys, but we're called a fire-based EMS system by others. But on a daily basis, we want to sort of mitigate risk. And this concept is consistent with what we call our incident response policy that has an appendix called the operational doctrine, which allows us to make judgment calls that entail some risk in furtherance of life safety and community risk reduction overall. Like we downgrade when we don't want to be there for a hangnail when someone down the street is having a heart attack, right? Supposedly, right? And we assume risks that is reasoned, reasonable, justified, deliberate, and communicated. And it requires, however, that we refuse unnecessary risk. And that is not being risk averse, but refusing unnecessary risk. So this is where it would be good. I'm going to change seats with Mario, and he's going to talk about this path to preventing the system-wide recurrent errors in applying both QA and quality improvement principles. So I turn the stage over to Mario. Here he is.
Hello, good evening, everyone. Thank you, Dr. Stone. Also, thank you, Dr. Sagel. I really appreciate the opportunity to talk to you all about this topic tonight. So what you see here on this slide is how the department moved from addressing individual cases to identifying systemic issues and then addressing the risk factors that contributed to what we identified as inappropriate downgrades. And so you see on the left, you start with the individual cases. In typical fashion, we handle those on a case-by-case basis, focused on remediation, but really focused on the individual provider. During the course of reviewing these cases, we encountered a few sentinel events that really made us realize that one, the risk level was high, but also that it needed to be managed at the systemic level. And so using our system, EMS monitoring system surveillance, we identified several systemic issues. And so, I'll list those here, or I'll speak to these here. Lack of training, lack of guidance, lack of process. And I'll address that sort of in the broader context. Having trained as a paramedic, having been an EMT before that, having been a first responder even before that, I think myself and most folks feel comfortable identifying a sick patient versus a not sick patient. And then, when you first come into a system that's a tiered system, ALS, BLS, you do gain some training and then some experience in terms of identifying ALS patients versus BLS patients. But what someone in my position did not necessarily have was guidance around how it is that you could safely downgrade from ALS to BLS. And so I think that was sort of a gap that we identified in terms of training and guidance around the downgrade process, and really even a lack of a process in that space. That was compounded by not really having the documentation that we needed to effectively track what it is that we were doing. And so what that allowed us to do was to identify several risk factors for improper downgrades. And then that led us to develop risk management strategies, including a downgrade process and a pilot. And that became the basis for what it is that we'll talk about next. So let's talk about risk factors and mitigation strategies. So what you'll see here are three categories of risk factors that we identified, starting with lack of engagement. For a number of different reasons, we identified that ALS providers were not engaging patients dispatched at the ALS level. As a consequence, what was often happening or we were finding was that they weren't necessarily assessing these patients adequately at the ALS level. Not surprisingly, what that meant was that they weren't necessarily recognizing what were truly ALS patients or even high-risk chief complaints. And then compounding all of that was due to the lack of guidance and process around downgrades, there was not a good patient handoff between ALS and BLS providers. And I'm sure you're all aware of just the dangers in any patient handoff, but particularly in this case from ALS to BLS without really a structured process around it. We found that that was creating a lot of risk, again, to providers, to patients most importantly, and then also to the system. And then rounding all of that out was just not having the documentation that we needed to support effective tracking and evaluation of the downgrades themselves. And so we developed 3 strategies to address these risk factors. The first thing we did was put a process around downgrades. And so that process requires a minimum level of patient assessment and then sufficient communication between the ALS and BLS providers, and really a meeting of the mind between those 2 charge providers. Second, we developed a tool, downgrade checklist, to help inform downgrade decisions. And then lastly, we implemented documentation requirements to, again, help us get a better sense of what's going on, help us to track. You can't manage what you don't track. And that's really where we were finding ourselves. And so we'll discuss each of these strategies in turn. Okay, so let's talk about the downgrade process first. And when I start this, right, we've talked a little bit over the last couple of slides, we've talked about a lot of the risk that's associated or potential risks, right, associated with downgrades from ALS to BLS. And we want to make clear that the county, MCFRS, continues to support ALS downgrades for all the reasons that Dr. Stone discussed, right? There's really, if you look at the numbers and you look at patient acuity and a lot of the other factors that really informed the decision to move to this model, there is a rationale for why it is you would logically move to a system where you can free up ALS providers when a patient does not require ALS transport. What we were trying to do was just make that a process and a safer process for all involved, and really address the lack of guidance and, again, process around ALS downgrades. And so what you see here is what the downgrade process requires. And so the first 2 elements, they're pretty basic, right? But it was important for us to put in writing what is required of ALS providers, even when they suspect the patient may not require ALS transport, right? You need to do a full patient assessment. You got to use the full range of tools that you have available to you. To do that, you've got to get a complete medical history. And so the important takeaway for these 2 elements is that all ALS dispatched patients should receive an ALS assessment. And there's good reason for that, right? We use clinically validated dispatch protocols. So it's not unreasonable to think that there's at least a rebuttable presumption that an ALS dispatched patient requires ALS transport until you are reasonably certain that they don't. And so there's, I know certainly from my experience, there are probably a lot of providers who are watching this now thinking, I get dispatched a lot of ALS calls that don't end up being ALS. And that's not to say that that's not true. What it is to say is that there was a reason why those patients were dispatched ALS, and we really need to get at that reason and make sure that we understand it and we can rebut it before we say these are BLS patients, they don't need ALS transport, because that's the only way to really do downgrade safely. And then the third element is really the most important one, because it created a break in the action, a timeout, to allow for a structured handoff from ALS to BLS providers. So let's talk about that. So what is the downgrade timeout, ALS to BLS downgrade timeout? And so it consists of 4 discrete elements, each of which is required. So the first thing is we need to have a face-to-face discussion between the charge ALS and BLS providers. So we don't want providers to be like boats passing in the night, right? So you have ALS getting on the scene, determining that the patient is BLS, and then BLS coming on the scene and essentially like a wave and you've got this, or this patient's BLS, you don't need us. And so we wanted to really get at that piece. Relatedly, right, we wanted a full exchange of information on assessment findings and a working diagnosis. And then finally, the completion of a downgrade checklist in the EPCR report. And that accomplished 2 things. We'll talk about the checklist next. But one, it allowed us to insert a decision tool into the process to inform these decisions. And 2, it also contributed to documentation around this process, which was getting at that other risk factor that I identified earlier on. And really the goal, right, was to get to a mutual and informed downgrade decision that was consensual, right? And it was mutual between both the ALS and the BLS charge providers. And so we'll talk about that. So let's talk about the checklist. And so Dr. Stone talked about this a little bit, and I'll talk about it at a high level here in terms of the checklist being a clinical decision tool. And it really, what it does is it focuses providers on 5 categories of downgrade criteria. And we'll get into the specifics of those towards the end. But categorically, we wanted providers to focus on the presence of high-risk presentations or chief complaints, high-risk assessment findings, high-risk 12-lead EKG findings, the need for or the performance of ALS interventions, and then as Dr. Stone was talking about before, important foresight considerations, and to highlight here, right, the possibility of patient deterioration based on sort of the mechanism and pathophysiology that you were presented with, but also the ability to relieve human suffering. Not every patient that is in pain requires ALS for other reasons than simply to relieve their human suffering. And that's something that Dr. Stone has really emphasized with medics generally and also as a part of this process. And so when we developed the checklist, we did a little bit of literature review, didn't find a lot out there, but you'll notice that the checklist itself is not that dissimilar from CDC triage guidelines around history, physiologic findings, diagnostic findings, and interventional needs. So we put together a process, right? We built it around the checklist. We needed to validate it. And so that's the next slide here. So what we did is we validated the downgrade checklist by doing a retrospective chart review of all the ALS to BLS downgrades that occurred in our system during April of 2019. And so the way that we did that was our system surveillance software applied the checklist criteria to each patient chart in order to classify each patient as suitable or not suitable for downgrade. A paramedic reviewer in the QA office then independently assessed each patient's suitability for downgrade from a clinical QA perspective. We presented the findings of the study at the NAEMSP conference in 2020, so the National Association of EMS Physicians. You see the poster in front of you now. It's a bit of an eye chart, so we'll discuss the findings on the next slide. And we also recently updated data analysis, so you get the latest there. So let's take a look at the results. And so what you'll see in the retrospective review, we had an N of 945 ALS downgrades in the month. The system surveillance software applying the checklist that we had developed classified 622 of those as suitable for downgrade and 323 as not. Then we had the QA reviewer, paramedic QA reviewer, come in and concur or non-concur with those findings. And so that reviewer concurred with the suitable classification 73% of the time, and with the not suitable classification 31% of the time. So that's a big difference, right? In terms of positive predictive value, it telling you this is a good downgrade, and the paramedic reviewer agreed 73% of the time, and the checklist telling you this is a bad downgrade, and the paramedic reviewer only agreed with that assessment 31% of the times. And so what that meant for us was the checklist was simply better at identifying a good downgrade than identifying a bad one when compared to the assessment of the QA reviewer. So that was not necessarily a bad thing. It actually was a good thing from our perspective, because the intent was to really validate when downgrades are suitable, even at the risk of over triaging patients who may have been appropriate for BLS transport. So we didn't want folks to say, well, it said it was a bad downgrade, and so that's what we want you to focus on. We wanted really the focus to be on making sure that we capture all patients who are good downgrades, so it had greater specificity in that sense, right? Like it could identify what a good downgrade was. It couldn't necessarily identify what a bad downgrade was. So again, you really need to make sure you were making a fully informed decision to downgrade. So we had a validated checklist in hand, and we moved on to the last risk factor, which was incomplete documentation. And so what we did is we established documentation requirements to facilitate the tracking and assessment of ALS downgrades. And basically what it comes down to is if the checklist criteria is met and a suitable downgrade is what it is that it finds, there's no need for additional documentation by the ALS provider. These patients will still get a full patient care report at the BLS level, but there's nothing additional beyond the downgrade checklist, which itself serves as documentation to a certain extent for the ALS provider. If the ALS provider was making a decision to downgrade that was not supported by the checklist, they are required to write a downgrade narrative. And again, Dr. Stone has mentioned that the ability to downgrade from ALS to BLS is really within sort of the paramedic scope, but we wanted to put the onus on them because again, if you weren't essentially in consensus with the checklist, you were accepting some element of risk. And so we wanted to make sure that one, that was fully documented, and two, it was fully informed. What we did is we supplemented our system surveillance tool, allowing the QA team to identify downgrades and missing reports. And bottom line, as I was talking about already, ALS providers can deviate from the checklist, but the burden is really on them to justify why a patient does not require ALS transport. And we think there's good reasons for that. Dr. Stone has made it clear he wants us to err on the side of caution. Again, as I mentioned before, the dispatch protocol is clinically validated. And then again, the downgrade checklist was also validated through our own internal QI study. So lots of good reasons for why, if you were going to diverge from the checklist, we wanted to make sure that you were documenting that appropriately. On the flip side, the downgrade checklist does provide a safe harbor for providers who comply with the downgrade process. And we thought that was a good thing too, in terms of incentivizing the use of the downgrade. You use the downgrade tool, it tells you you have a good downgrade. We know that it has good positive validity when it tells you that. We felt that that was a good way to say there's some safe harbor associated with your downgrade there, because you've done everything you needed to make sure that we're managing and mitigating the risk to the greatest extent possible. So at the end of 2019, we piloted the downgrade process, including the timeout and the checklist at 3 stations. One is a career station with only AFRA, so only paramedic engines. One was a combination station with both paramedic engines and a BLS transport unit. And one was a combination station with only BLS transports. So as with the validation study, we used a paramedic reviewer in the QA office to independently assess each patient's suitability for downgrade. And what we found was that the QA reviewer classified a downgrade as appropriate almost 80% of the time when the checklist was used, but only 70% of the time when it was not used. And so that was a statistically significant difference in terms of how the use of the checklist was improving the percentage of downgrades that were classified as appropriate by the QA office. In addition, the units in the pilot study had fewer missing downgrade reports, so we also improved the documentation around downgrades. And then finally, we found that implementation of the downgrade process did not result in an increase of ALS scene time in the setting of a downgrade, right? And so whether you were using the checklist or not, it took about the same amount of time for when an ALS provider was on the scene in the context of a downgrade. So overall, we consider this to be a successful pilot, and that allowed us to go to the next and final piece here, which was codifying the process into policy. And so the ALS to BLS downgrade process was codified in Fire Chief's General Order that was issued in November of 2020. One thing to note here, in MCFRS, what we try to do in terms of our quality processes is to segregate them from the disciplinary and employment and/or membership processes for providers. But at the same time, we recognized that we needed a mandate here and a mechanism to make sure that folks were utilizing this process, because again, it was very important for us to mitigate the risk that we had identified around downgrades from ALS to BLS. And what you might see in the document here is that the general order begins with a requirement to engage. And so patients dispatched as ALS must receive an ALS assessment before moving on to other elements of the downgrade process. And I've talked about that already in terms of just making sure that patients dispatched as ALS actually get ALS engagement and ALS assessment. So I'll turn it back over to Dr. Stone and talk about what has happened since the downgrade process was codified in policy. Thank you again.
Okay, thanks again. So a little break in the action before we go on to some of the data about downgrade compliance and our quality management interventions. Let's introduce the first part of the case for us to ponder before the dispositions at the end of the talk. And then an additional one by Mario, right? So how might a call like this be dispatched? So ambulance A and paramedic B are sent to a 34-year-old working construction specialist who develops posterior chest wall pains soon after swinging a hammer. And as time went by, he noticed that he became more difficult to move his left arm without it hurting. He described some rib soreness, but in some tingling in the arm, right? And so the coworkers he was stoic, but his coworkers said, hey, we're worried about this. And his boss was like, hey, man, that doesn't sound normal. So how might something like that be dispatched? Well, because the patient is under 35, there could be different variations of the MPDS 10 card that could be involved, including a 10 alpha dispatch, depending on exactly the details. But in this case, a 10 Charlie was at play, so that brought a single ALS clinician to the scene. And this is the snapshot of the data that's obtained by the responding crew and a stoic patient who minimizes his complaint and tells the medic, I think it's just back pain, and I have been working today. But it is notable that the level of the back pain is not low back pain, but it's up to upper torso, primarily feels posterior. So let's again hold our thoughts on this and defer the disposition. But the same question applies. Could this go in a suboptimal direction? So as we began to measure and look at the downgrade paradigm, we began with a baseline, and this slide is from the latter part of 2022, where we were measuring and trying to figure out what is the status of the compliance with this new direction. And we knew that we were facing some headwinds in getting the word out and then getting people used to doing this each time, every time, etc. So this Power BI, which is what we use for our system surveillance, and it allows us to get cumulative calls into a database and then report them in a very aggregate fashion and a very ordered fashion. This slide from June to around Halloween of 2022 shows the most pressing metric here, and that is the percent of the downgrades with a checklist done and the process being followed. And over in that left lower corner, you can see that the goal is 90%, but the dome shows that the red color, the meter, so to speak, is up around 41.4%. So you can see that we were facing these early headwinds in trying to get our downgrade compliance up. And then the other thing this will show you is we can look at the downgrade with checklist by shift or by battalion, and one can see from this graphic that a specific battalion and or shift was clearly struggling the most, and we attributed that potentially to some factors. So if you look at the lowest percentage by battalion 1 in one of the shifts, that percentage is 14.7%. And we looked at potential possibilities why that might be so, and that may be attributed to things like high volume, high call volume. You're getting your you-know-what handed to you every day, dense population with proximity to more than one hospital, and those factors might subordinate the issue. I can see hospitals down the road, I can see the hospital. Maybe it's okay because it's not as much of a risk if we just let BLS take that patient and finish out the transport. So we thought that there were potential things that could explain some of the differences in the battalions, rural versus urban, and some people were even making guesses as to whether the culture of the individual shift could have been playing a role here. But this sort of shows the reason why we asked the question about how well we were going to face the headwinds that say a patient's needs do not change depending on where the medic is coming from, and was that axiom really followed, and if not, what are some of the contributing factors? So about 3 years after the poster that Mario described, and I might add very modestly because he said we presented, I will say Mario presented the 2020 NAMSB poster. I had the pleasure of presenting this one at the 2023 NAMSB meeting because our goal is to try and put something in the national arena annually. And it simply brought to light through numeric aggregate data some conclusions that we suspected from the anecdotal experience, and that is, remembering my axiom from a little earlier, a patient's needs should not depend on non-medical issues. Here we see that a retrospective study from the calendar year 2021, looking at our downgrade opportunities, showed how we handled them from ALS deployments, and it showed that there was indeed a difference in the likelihood of a downgrade depending on certain factors involved in the deployment, where the arriving medic was coming from. There was a statistically significant odds ratio and an 8.5% increase in the downgrade frequency in the cohorts attended by a paramedic engine medic versus one that's within a legacy medic unit that would probably transport, or even within the few chase cars that we had in the county that came in a Chevy Suburban. And when the medic is there and you're on a legacy medic unit, is the medic more likely to, quote, find ALS work to do? So here we look at the overall downgrade frequency, which isn't alarming at all. If you're dispatched, if you over dispatch and you dispatch 25% of ALS or 25% of ALS patients, get about, but we have a dispatch of 39 to 55. 29 to 35% or 39 to 45% ALS dispatch. You're going to have quite a few of those people, and in our case, at least 40%, that it's reasonable to downgrade in aggregate. So I wasn't at all alarmed by the 40.7%. But notice, if you look at the chase card cohort, it was 41.8, and with the power of the study, the N number, that 1.1% difference did not reach statistical significance, p-value 0.185 or 0.1825, but there was a statistically significant difference of 8.5% with a really tiny p-value with the medics coming off the engine. And so what that means, that the odds ratio being 2.3, is that we wanted to make sure that people knew that that was the aggregate data, and made us want to put it out there that this really underscores the reason why there should be a process rather than just winging it, as I said in the beginning of the talk. Now, within the jurisdictions that may not have medics that are divorced from the clot, the practice of flip-flopping the driver and the medic, I've seen that to be common outside of MCFRS, but the same tenet applies. This study speaks to the fact that there are potential consequences for each deployment model depending on if you divorce the clot or not. So if you are flip-flopping, at least the medics, if something happens, the medics in the front driving, that might be calculated as a different risk in other EMS operational programs, and you may want to adjust to that deployment model, but still it's not ideal that the medic isn't in the back when someone's deteriorating. So it underscores a structured guideline of care rather than just winging it. And this was a poster that sort of alerted us to underscoring why it's a process, not just where the medic is coming from. And this then leads to the question of how we address shortcomings using the quality improvement model with a PDCA cycle. If our starting point is we're facing headwinds, how do you get the word out, right? So we chose a multi-pronged informational blitz. In the beginning, we had a boss talk video that Mario co-hosted. But overall, we chose a three-pronged system of education, information and education provision. And the emphasis that you can see in this particular slide is the process must be paramount and consistent, as we've been talking about this whole time. The requirement to engage is foundational, and emphasizing the totality of the information from a thorough assessment, so to speak, right? This was the first of a trilogy of 5-minute lineup drills that had to be presented by station officers, which are usually captains and lieutenants at every station over every shift. And so on the career side, that's 3 shifts times 35 firehouses plus 2 rescue squads. That's a lot of officers being asked to get the word out. But that's the way you do it. If you want to try to get the word out, you need help in doing it, right? And an area of emphasis is that our mandate is not about micromanaging individual decisions, as it is emphasizing that the process is primary. And the other thing that goes along with that is that the stakeholders are a triad of all involved. Neither the BLS clinician nor the station officer, if they're present, can be complicit in a bad decision that's in progress that could involve an ALS clinician involving the patient's well-being. So BLS officers, ALS clinicians, all are important to be involved in this. And this shows sort of an easy algorithmic graphic underscoring this process. It's not rocket science. It's relatively straightforward, the nature of our expectations here. Now, with that, we got a lot of what-if questions about the issue of requirement to engage from those querying, when am I on the hook? What's the trigger that puts ALS clinicians on the hook? So we tried to define something reasonable and kind of self-evident and commonsensical, though we're really cognizant of this issue that although validated, MPDS over dispatches, and they're limited by what the caller's information being told to the call taker over the dispatch phone. Given that, we wanted to avoid a pitfall of human nature that would facilitate bad decisions brought out by ALS clinicians showing up on the scene and not doing the basics. Now, we know that they're over dispatched, but should ALS clinicians be walking through the door and having a habit of saying something like, "You don't need me, do you?" Or "You're okay, aren't you?" or BLS clinicians, especially the lesser experienced ones, looking for brownie points by almost reflexively waving off medics when they look okay, that priority 3, and saying, hey, I think we're okay. And cumulatively, they know the medics like that, right? So given that the dangers of that kind of cultural issue within, with the headwinds we're fighting, there was not only the issues of not necessarily being able to detect the tricky patients we talked about, the natural history of illness and injury, but there's these rare isolated, horror stories of suboptimal outcomes that would have been prevented simply by engaging. So a typical case in point that may happen sporadically is where medics on a paramedic engine that's also dispatched for manpower, blocking unit, whatever it is that they need people for, they would silo themselves into the patient stretcher bearer role, or I'm here to help you with your bags role. And we've seen patients that were probably in the early stages of deterioration being wheeled out by a crew, including a ALS driver, for instance, or someone who's just in the right seat. But I'm not here dispatched. I'm a medic. I'm a medic helping out, waving goodbye to the BLS units, who then get a vital sign down the road, and now the pressure's 80 over something. And where's the engine? It's on the way back to lunch or whatever. So we've seen some horror stories about that. And what's that about? The curiosity to engage, the gumption to engage. So we needed to identify a trigger, at least by a language everyone could understand, and that is the ALS dispatch is a trigger. And yes, we know we over dispatch, but that just raises the issue of investigation. And then the second major thing is the ALS clinician making physical or visual contact or within shot of the patient in a reasonable way, because we know that BLS will sometimes wave off medic units en route, medic units coming from further away, and all that is reasonable operational processes. But if the medic is has a shot at the patient, the medic should be curious enough to say, what you got? I was dispatched out here. Tell me about it. And the other thing is that for the issue of brownie points and EMTs, they need to be well informed before they make a wave off decision themselves. And that is the requirement that they can't cancel folks en route before at least the most basic of BLS assessment is done, like history, physical exam, vital signs. And so this 5-minute lineup drill sort of underscores the requirement to engage and what constitutes, hey, am I on the hook here? Because we got those questions. And this 5-minute drill that caps out the trilogy I talked about is on creating the chronological opportunity during the encounter to imply the tenets and goals of the process that Mario was talking about, and I mentioned before that, and Mario was really detailed about. A downgrade timeout is a bi-directional exchange of information that links brains. 6 sets of eyes, 3 brains are better than 1 and 2, right? All levels of care and auditory perspectives, stimuli are together making a decision. It suborns more than a simple coercive exchange. It forces you not to be able to say, you're good here, right? You gotta have that timeout. An opportunity to work through and fill out the downgrade checklist that we've talked about, an opportunity to consider everyone, what say you, what say you, what say you, and an opportunity for the medic to recap all of the elements of decision making, right? And so this makes for a patient safety step that's no different than you being wheeled into surgery and they want to prevent you, the surgeon, from amputating the wrong leg. We have this type of thing in American medicine all the time, and EMS is a profession. Why shouldn't they be a party to a process like this for the greater culture of patient safety? So combining all 3 angles of quality management interventions, including these 5-minute drills, fire chief's general order that we codified with other continuing medical educations like hammering away at this in class, and the SITS boss talks that's at the bottom of the slide that Mario participated with, all coupled with continuing education and culture, we're able to see a little bit of the fruits of our labor here. The overall downgrade percentage of downgrades with evidence of process completion number went up to the mid-80s in percentage by mid-2024, having started well under 50%, as we showed you in the last slide. That was this. So this is from 7/1 of 25 through a little later on in the summer. And the compliance remains somewhat stable during the same 7-month year-to-date period a year later. So now 2025. So this shows 82.5% on that little meter that I was talking about early. And the individual daily variation has been within a range of common cause variation. If you look at the control chart in the middle, we're not having a lot of outliers there. And just for good measure, super up to date, moving beyond just the first days of August, this is almost just up till a few days ago. Look at the percentage here at 86.1 and a control chart that shows that on 2 of the days, it actually got close to 100%. So individual days, with 100% compliance, we can see that what we were trying, the word is out there, and our guys are doing, bang up job with being with these credentials. I will at the end say a little bit about protocol, because I know that I said at the beginning, we're not telling you in any way to change your compliance with protocols for your areas. So I promised. I said, hold your breath. I promised. Let's go into the aftermath of the scenarios. So here's incident 1, the 19-year-old basketball player that was for which we called a timeout, right? There wasn't a lot of immediate concern, as he says, I think I'm good. There were setups to say, I think, maybe he had a vasovagal episode, maybe he had something more benign, young person's fainting spell, but it was fainting, right? The BLS crew, because the dad was saying, are you sure I can take it to the pediatrician tomorrow? Because remember, it's a basketball game, as I was saying before. And the BLS crew, their instinct, as in the medics just arriving and listening and getting recapped by the other EMT spent some time and said, look, he passed out. I mean, I had to catch him. Dad, we're giving you the advice to go. And so that takes a little while. And the ALS clinician is probably thinking, wow, we really did our best to convince him to go. He almost didn't go. But what came of that was not necessarily following a process, right? So the BLS crew takes the patient to the hospital, and there's a good, reasonable turnover by the BLS crew to describing what happened, and the patient's still stable at that time. And someone, brings the case as they're deciding how to get the person into a room, because this was a little while ago. We had crowding problems, but they may be not at crisis. So someone tells the doc about the case, and the nurse said, did anybody do an EKG? And the BLS clinician said, not to my knowledge. I don't remember the ALS clinician even considering one. They bring the case quickly to a graduate of the University of Maryland School of Medicine Emergency Medicine Residency Program, where it's been hammered into their head the value of EKG interpretation, and they don't like the coved ST elevation in V1. For you BLS clinicians, I'm not asking you to know what that is, but it jogs the mind of this Maryland graduate, and they're saying, darn, that looks like Brugada to me. And he shows it to the other double coverage guy, and that says, hey, you know what? You're right. That looks weird. So they keep the patient in the emergency department. They fax it over to the cardiologist, and that person says, you know what? What was the story? Passed out. Gee, I know this sounds weird in a 19-year-old, but let's keep him overnight, and I'm going to have EPS look at him in the morning. And gosh darn it, if they didn't put an AICD into the kid. It's a rare heart conduction system issue where, like choking, where you can get an 11 alpha, someone choked and now they're fine, versus an 11 echo and they're in cardiac arrest from choking. This is one of the things where the one syncopal episode might be your only chance to have this heralded. And when you get an AICD, you live a normal life, because if something happens, suddenly you're shocked right out of it. And we've had Brugada patients who never got that first warning, or Brugada patients who did and didn't get seek treatment. And then they wound up one of the few cases of cardiac arrests. And so think about why I asked whether this call could, how this call could go. And although I'm not necessarily saying that all ALS clinicians would know what Brugada is, it's being taught a little bit more than it used to. The fact is, he was a syncopal episode that was otherwise unexplained and was not clear-cut vasovagal. And by the way, young athletes can have IHSS and other conditions, and we've seen them collapse on fields before. So think about what would have happened if it was a downgrade checklist. Maybe the person would have gotten that EKG, and even if the downgrade, the patient would have been on the way and transmitted to the clinician. And it's just one of those tricky situations. But if you follow a process, syncope is a high-risk chief complaint, and we're saying you got to get an EKG with syncope, right? So there's one, right? In really bad scenario 2, you remember the patient who was swinging the hammer. In the unit after downgrade, he starts to feel a kind of a tearing scapular pain and worsening discomfort. People almost liken him to having a kidney stone between the shoulder blades. He's a little bit agitated because he's really in a lot of discomfort, can't get comfortable, squirming a little bit. And it's like, my wife described childbirth like this, and I feel like it's in my back. And this is where I'd like you guys to type in the chat box. Anybody want to take a crack in the chat box? Can we see the chat box of what this might be? And I'll pause for about 30 seconds or 45 seconds to see if anybody's wants to take a shot.
Aneurysm, AAA, aortic dissection, AAA.
Okay. So we have aortic dissection, AAA, etc. All right. So indeed, can anyone here say thoracic dissection? Now you can dissect in further down, but this was actually, it turned out, someone who would have had a different blood pressure if you took it on one side and the other. But think about, why this call could have gone better if there had been a little bit more of a process, right? Now, I understand it sounds kind of musculoskeletal. He swung a hammer. He says his ribs are sore, but there was no EKG, and that may have been possibly revealing. And there's the issue of why his blood pressure, with this totality of the evidence, is 222 over 122 in a person who had no idea they had high blood pressure and who smokes. If you're seeing where I'm getting, were the clues worked through to inform the decision. So BLS gets him to the hospital. He's got differential BPs in each arm. The chest x-ray shows a wide mediastinum. Need I say more? But the other thing is, it could have been an epidural if he had other things, like if he had been someone with a fever, tachycardia, really bad back pain, squirming, and by the way, that he's recovering from addiction and had an IV drug abuse history. This could have been an epidural abscess, and the person's tingling, and the epidural abscess can give you neurological deficits in your lower legs. If you get these things, don't forget what is a high-risk chief complaint. It can also be a kidney stone. And if it's a kidney stone, you're not going to kill the guy by not upgrading him, but do you want to relieve human suffering? Toradol is often effective med. Some surgeons say it sits on platelets if it had been a dissection, but I haven't seen anybody killed with Toradol, but it's about helping to relieve human suffering. The guy was squirming all the way to the hospital. I'm going to give Mary an opportunity to go over one of his cases, and he's not going to keep you here with bated breath. He's going to give you the actual disposition right away. Mario.
Great. Thank you. So we'll use this last scenario to illustrate a broader point about the mismatch between patients and resources that kind of underlies what it is that we've been talking about tonight. So 2,300 hours, you're dispatched for a BLS sick person at an assisted living facility. And in this case, you're on a medic unit, and you actually have 2 ALS providers. So you actually don't have an opportunity to downgrade to another unit. This patient is going to be transported by your medic unit one way or the other. And so you arrive on the scene to find a 78-year-old female self-ambulating in the lobby. She complains of general fatigue that started this morning. She's alert and oriented. She denies chest pain, no shortness of breath, no other complaint. She has a history of hypertension, but no other pertinent history. And these are her vital signs. 130 over 90, pulse is 70, 96% O2 on room air, and respirations 15, right? So, what are we thinking here for this little old lady who's feeling a bit fatigued? Let's go to the aftermath. As Roger said, I won't keep you guys in suspense. So working diagnosis, little old lady, she's got general weakness. You BLS transport her to the emergency department, right? You are on an ALS unit, you are an ALS provider, but the call was dispatched BLS, and so you treat it as BLS, and you do a routine patient transfer to the nursing staff. The room nurse, after you leave, eventually performs a 12-lead EKG per standing orders, and what do we think it showed? I'll tell you.
Okay.
You return to the ED the next morning with another patient. You ask about that patient, and she says, that little old lady you brought in last night, she was having a STEMI. And so what happened here? As I noted, the patient was dispatched BLS. She presented with a high-risk chief complaint, right? So general fatigue in the setting of an elderly female, very much an anginal equivalent, but we didn't actually, or the patient did not receive an ALS assessment from the charge medic. And so what I'll share with you all is, this is a call that I ran, not in Montgomery County, but when I was in Virginia with the City of Alexandria Fire Department. And I was the charge medic on this call, and it was a very impactful call for me. Not while I was having the call. I thought when I ran the call, it was pretty straightforward, and I was just holding this patient's hand on the way to the hospital and dropping her off as a BLS patient. But very impactful to me in terms of understanding what it is that we've been talking about tonight, right? And so just a few things to share for you all. And I'm actually taking this from a colleague of mine who's actually watching tonight, who has stated this in the past in different forms, right? Patients are not intrinsically ALS or BLS. We are the ones who apply those labels to them. And we do that because we want to determine the level of resource to send them. So it's not really about them. It's really more about us and what resources we're going to put against their requirements. And so what that means is that we can have a potential mismatch between the level of patient and the level of resource. And that can occur in both directions, right? We can dispatch ALS to a BLS patient. Again, they're not intrinsically ALS or BLS. It's a matter of the resource that we send. And BLS can be dispatched to a patient who requires ALS assessment and transport. And so in this case, from a resource perspective, this was a patient who had a high-risk chief complaint that should have received a full ALS assessment to include a 12-lead EKG on the scene or during transport, but didn't get it. And so we had not necessarily a resource mismatch, we had an engagement or a lack of engagement at the right level, which is something that we've talked about repeatedly during the course of our presentation tonight. And so what's the safest way to avoid consequences like these? And it's what we've talked about, right? We need to provide as clinicians the appropriate level of assessment in both situations, right? Whether you're ALS to a patient dispatched ALS, and ALS to dispatched BLS, as in this case, right? Or as a BLS provider, and Dr. Stone talked about this, right? Because part of what we see, that our presentation today is not about downgrades. Well, it's about downgrades. It's not about wave offs, right, from BLS to ALS, but we noted that it's very much the same risk, right? So you dispatch a BLS resource to an ALS presentation, and there's the same risk there if we don't actually allow ALS to engage that patient and just wave them off thinking, oh, I can handle this at the BLS level. This patient is not sick. This patient is not ALS. And so we need to be very careful about both downgrades and also wave offs. And really they're kind of two sides of the same coin in terms of mismatches between either the resources and or mismatch between the engagement that we get with that patient. So this is something, I can't say it'd be nice if this was a neat story and this is what led me to dedicate the time and the effort that we put against the downgrade work that we did here in the county, but it was probably related in terms of making it clear, at least to me, what the risks are involved when you don't engage patients at the right level. So we'll turn to our summary slide here, and I'll just sort of encapsulate what it is that we've talked about today. So we start off by talking about ALS to BLS downgrades and the advantages that they potentially provide, and really them being within part of the ALS credential, but also the fact that there are pitfalls, and these pitfalls create risk, and we need to manage that risk. And so what we in MCFRS did was develop strategies and tools, including the downgrade process and the checklist that we've talked about, to enhance patient safety and, again, mitigate the risk associated with ALS to BLS downgrades. We followed that up with a pilot study that allowed us to identify the benefits and also the implementation challenges associated with this new process. And then once we had a successful pilot and validated tools, leadership supported us in terms of codifying that downgrade process in policy. And as Dr. Stone mentioned, this didn't, in the pilot, we saw that it was impactful immediately, but it wasn't adopted across the board immediately. And so compliance improved over time, and we had to do things to make sure that that happened. And so it just sort of shows you the value of QA/QI science in terms of identifying a problem, investigating what the problem is, identifying the risk factors, developing strategies, validating strategies and tools, and then getting to a point where you saw improvement in terms of the care that we were providing to patients. So with that, I will move to the next slide and we'll open up for questions and I'll bring Dr. Stone back. Thank you all again for the opportunity.
Yeah, very informative, very interesting concepts.
Yeah.
I don't look at this as anything to do with rationing care. It looks more like increasing availability of care by less downtime of your ALS providers, because ALS has become a limited resource. But I was going to give you two small questions just as to see where that I was curious. So the first question would be, if an ALS procedure is performed, can you downgrade at that time, or is the paramedic locked in? And I'll give an example of, say, you need intraosseous access because you couldn't get an IV for a trauma patient. Is that paramedic now locked in, or does that mean it's still subject to downgrade?
Wow. So you guys can still hear me, right? Jeff, you can hear me?
Yep.
Okay. So let me answer globally and then zoom in, and I'll give Mary an opportunity to chime in if he has, because we are definitely partners today. The overarching thing is we're trying to suborn good decision making, and we already said that if you that we don't hold people to not deviate slightly from the checklist. For instance, if you have a chronic hypertensive person with a high blood pressure, it may not be enough just because he's got one abnormal vital sign that you can otherwise explain. It just means that you have to do a downgrade narrative, which explains and documents what your thought process was. I want to also say that one of the questions we received is like, hey, if I do an EKG, doesn't that make me on the hook? And the answer to that is no. We did not want to hogtie our people from being incentivized to get the data they need. So usually the EKGs, when they even purported to downgrade, we were like a final icing on the cake. I have 7 pieces of information. Just want to get the EKG as the 8th, and we didn't want to make him say, oh, if I get that, then I have to go, and then they don't get it in the first place. So on a global basis, we don't want to micromanage downgrades such that just because you did a procedure, it means you have to upgrade the patient. Now, zooming in a little bit, on intraosseous, one could make the argument that drilling a bone is kind of invasive. And secondly, the indications to say, if I can't get an IV, I better drill a patient, usually are associated with higher acuity. So I would generally say IO provision is probably usually more related to upgrading a patient. And we would really wonder why the downgrade occurred if it was in the setting of an IO. But I do want to answer the greater question is, it doesn't mean that automatically any procedure is automatically an upgrade. Another example that might favor that is you have someone who you wanted to give some non-opiate pain control, and I would have to look at the protocol book about what you're allowed to do in terms of BLS transport with an IV lock in place. But if someone got a dose of Toradol, not an IV lock, but if someone got an IM dose of Toradol, I don't think that necessarily means they've got to be upgraded, depending on what the totality of the evidence is. And I kind of hoped that answered as a question before. I had a couple of final slides before we leave, and you toss it to the end. But I'll pause there and see if that helped answer your question.
It did, and then I had a second one and that was, say it's a BLS unit gets there first, the BLS unit then assists the patient with taking their nitro. The patient takes their nitro, the pain goes away, but they still want to be checked out at the hospital. But the nitro did what it was supposed to do in a patient with a diagnosis of angina. Where does that fall on your checklist?
Okay, so I would assume that the chief complaint is either chest discomfort or something.
It started as chest pain.
Yeah, and it could, or it could be anginal equivalent.
Right.
The focus there for me is not whether the patient got the 1 dose of nitro, but it's the totality of what the presentation is that brought the ALS dispatch there, and certainly the ALS clinician needs to engage. You have to wonder in a patient who needed their nitro and was having angina, whether it was unstable angina. So it gets back to whether this is a high-risk chief complaint that does not pass the checklist, but then also the totality of the evidence really doesn't favor a downgrade here. So we would not at the automaticity of X plus Y equals bad, but what were you thinking when you compared your decision making to the checklist? And oh, by the way, if you didn't even leave a paper trail, we'd have to just have you write a statement just to know what the heck happened and why it happened. So unfortunately, there would be one where we'd have to apply some tenets of QA, even though the overall goal here is quality improvement.
And then the next thing is you were talking about the checklist, and then you gave this thing where the checklist is the equivalent, or is the checklist the equivalent of a downgrade narrative? In other words, you know, I kind of don't see how the ALS provider who's examined the patient is exempt from writing a downgrade narrative, since they examine the patient. Would be, it's sort of like in the hospital equivalent, you have the primary physician who gets a consultant. The consultants write a note. The primary care doesn't write what the consultant says.
Okay. I'm going to turn that one over to Mario, because he also saw some other questions in the chat that he could address, but I'm going to talk about that issue. I think, Mario, you'd be very good to answer the question about why the incentive was given for, if you literally pass all the elements of the checklist, that is our carrot to counter the stick, about why the medic doesn't have to still write a downgrade narrative. I think that would be one to lend itself to your answer.
Yeah, no, and so I think, Dr. Segal, that's a really great question. And so certainly from the incentive structure perspective, there was a rationale for why it is the decision was made to say the downgrade checklist, the outputs of the downgrade checklist, right? It's not just you go through the checklist, it's in the EPCR. It captures all the things that you see here, and it is signed by both the ALS provider and the BLS provider. And so taking all of that into account, from our perspective, from an incentive structure perspective, certainly it was a way to say, hey, if you do this, you don't have to write the narrative. At the same time, I can completely see what it is that you're talking about in terms of, are we doing the documentation necessary to capture the assessment at the ALS level and the BLS level? And so, as I mentioned, I think a part of that, at least a part of that, is captured in the mechanism by which we do this itself. Another way that we capture this is, and you know, there's some challenges here potentially as well. The BLS provider is writing the report. What we did by putting the process in place and putting the timeout was make sure that there was we were fully, there was an opportunity for the full assessment, both at the ALS level and the BLS level, to not only inform the decision, but inform the BLS provider, who then carries that to his own patient care report, right? So if you take everything, sort of the totality of the fact that there was a handoff on the scene because there was a process in place and a timeout, there was the mechanism for the checklist that captures the assessment, and also the rationale for why a downgrade decision was made, and then the patient care report itself that the BLS provider writes and is informed by the timeout and the handoff. I think that's probably the best way to look at it in terms of getting to what it is that you're talking about, which is how do we make sure that the ALS assessment is captured and the vantage point of the ALS provider, if that answers your question.
Yeah, it does. It's all of this is, I mean, it's very interesting concepts. I think it's very relevant to the year 2025. Have you all looked at creating a pilot study for something like this? I mean, you have a lot of data already, but it just,
you mean,
you know,
beyond what we did to validate, well, we validated the checklist, so that was our internal QI study, and then we piloted it in a small scale before we rolled it out across the system. And so, what are you thinking in terms of a pilot study?
I'm thinking like as a pilot study for the state. It's not just Montgomery County that's low on ALS providers, because that's a limited resource. The state just changed and added an ALS reentry program to try and address this situation. This just seems like another spoke on the wheel that could address it. Again, I think it's not that we're rationing care. I think we're trying to decrease the downtime of ALS providers, yes, which increases the availability of care.
Yeah, I see Dr. Stone shaking his head. I think that's a big part of the reason why he thought this was an appropriate topic to share. Even though this is something we've done specific to MCFRS, it does have relevance more broadly. And so I think might be worth something, might be worth taking a look at to see how it is that we might be able to expand upon this.
Right. Now, I know that our Battalion Chief Dugan answered also in the chat somewhat, but by getting that EKG and then downgrading the call, doesn't that mean that I'm practicing outside my realm of care as a medic? I'm not a cardiologist and there's a risk I'll miss something. Did you want to take a shot at that?
Yeah, and so that's a really good question too, and something that we saw early on before we put this process in place and instituted the checklist, which is a lot of this has to do with human factors, right? And a lot of that has to do with incentive structures. And so what we were seeing was patients who were presenting with anginal equivalents who were not getting EKGs because it was 3 a.m. and the medic did not want to tie himself to the transport necessarily, right? So based on the medic's assessment, we're not making a judgment call about the medics thinking we've all been in that place, but based on sort of their gestalt of the patient, they thought that this patient was an ACS patient, right? But they didn't use all the available tools to rebut that presumption. And so what we decided to do in saying, hey, if you do an EKG, you don't necessarily have to automatically go unless there are 12-lead EKG findings.
Especially when it's an icing on a cake situation, where you're getting that as part of a larger assessment. And speaking to the question about whether it's outside your scope, thinking an EKG is not positive is not outside a medic scope. What's more important is that the EKG is transmitted so that when the BLS clinician arrives, something is not missed on overread.
Right.
And since we see that happen from time to time, this process puts a safety net in process for that.
Right. Yeah. And so that's the medical components of this, right? Part of this is human factors and incentive structures, making sure that we align incentive structures with what's best for the patient, which is that they get 12-lead EKGs if they have anginal equivalents. And then the medical piece of this, which is by which we mitigate this by one, we have the 12-lead EKG, two of these 12-lead EKGs are transmitted. And so what that really means is that you're not practicing outside your scope. You're actually practicing to the full extent of your scope, using all the tools available to you to make an informed downgrade decision.
So
when you say they transmit the EKG, do they transmit that at that time of the call? Because that gets involved with the base station, or is that being transmitted on arrival to the hospital?
It's transmitted before the medic leaves.
Okay.
It's transmitted to the hospital that's going to get the patient.
That's good. All right.
So one of the things is you're hearing my voice alongside Mario, because we're next to each other. I put this up on the screen because we get a lot of questions about what are the elements of the downgrade checklist. So we just want to make sure that people have the opportunity to take a picture of that. And so one of the things I wanted to talk about is just letting you know that there's an element of the downgrade checklist that where we really hammer away the issue of the historical component, that just getting the history, taking the time to get a history, will yield these potential 7 or 8 bullets of what constitutes a high-risk chief complaint. Anything that could be associated with airway. Don't forget syncope. Don't forget potential neurologic deficits, TIA symptoms that have since resolved, and we all take pause when it's a kid. Active or refractory vomiting is an anginal equivalent because there's also dehydration involved in that. Chest pain and an anginal equivalent, and clearly when you're not acting right, and you're not sure of the baseline, all of those really do herald the clue that would make you want to really dig deep and think twice before you would downgrade. Then there's things as simple as the vital signs, and don't forget respiratory rate. The forgotten vital sign these days is respiratory rate. And if you're blowing off your CO2, it could be, you have a metabolic acidosis, and that's associated with early sepsis and things like that. And then the interventions, or what you were thinking of doing as an intervention and why you were doing those interventions, comes into play. Again, if you're giving Toradol for mild to moderate pain with no other priority symptoms, maybe that's a decent downgrade otherwise. But again, don't forget, are you relieving human suffering? And is there a likelihood of deterioration? Again, that foresight. So I wanted to make sure that you all saw that and took a picture if you are interested in some of our criteria, which we put into EMEDS in order for them to have the downgrade timeout together and sign for that. And I talked about that, those that know me know that I love all things Maryland, from Oakland to Ocean City and everything in between. I also had the pleasure, in addition of bilingual education, of a musical one. And even in residency, the nurses knew me as the resident who like parodied stuff, Weird Raj Yankovic or something like that. So when it came to this topic, I had this idea, and for those of you that know and revere the band Chicago, I love their horn section. Is I grew up with myself. I took the liberty of parodying a little bit, and I don't know if this is going to work. I know that audio was on, but I don't know why this is going around. See if you hear this. Follow the bouncing ball and think about the song. If you're too young, sorry, but your parents made it on.
I'll add people, if you're looking for MIMS CME, please check for the link in the chat. Hit it.
I just want you engaged. Trombone.
There's a question in the chat for you.
Do they have any? Tomorrow comes and the next ship runs. Because you missed today. Anyway, we have a question in the chat box, and I'm going to go ahead and go ahead.
I'll let you address that one.
Yes.
So the question is, two-part question. Does MCFRS's policy of an ALS provider acquiring 1280 kg, leaving the patient without an online medical consult, align with the state's definition for abandonment?
Well, we're unaware of that being the case. We know that the patient is getting a continuity of care all the way through the patient encounter, right? And so there is I'm unaware of anything that says that in the absence of evidence where an EKG was obtained and there is no finding on the EKG in the best judgment of the medic. For instance, if the medic were there, they wouldn't be doing anything, but the system provides continuous bedside care of the patient and provides them transportation to the hospital with a qualified EMT, and you could add equipped with an AED, and the ability to call back medics. I would say that I'm unaware of anything that would rise to that definition. I was going to say, however, that we're not telling MSOPs that they should change their practices with respect to when they call online medical direction. But I can say that the infrastructure is not there for an individual discussion with a doctor 55 times a day on top of all the other online medical consults that we do have to do where we need a bi-directional conversation with the doctor. So we've put in place everything to assure continuity of care. Our presence is there 24/7, 365 at all levels of care. There's equal treatment in terms of our clinical practices that is given to every patient. So that's one of the reasons why I think that the concept of abandonment doesn't apply. Because can you make the same argument if they give Toradol and leave the patient? It's a clinical decision that they're giving Toradol? Is just because the medic may have given it and otherwise the patient's disabled, does that constitute abandonment? And I would say that maybe the right thing to do is that be one of the times where a medic can downgrade with the use of, Toradol. So does that answer the question or begins to?
And then the question
And
had
then
a
the
second
question had a
part
second part.
about.
You're muted.
I apologize. The transmission of EKG is otherwise codified in other fire chiefs' general orders to help us out with teeth. And what it says is that when you acquire a 12-lead EKG, it's transmitted so that the hospital, no matter how it comes, the hospital has a chance to look at it. For as long as I've had Project Lifeline in the emergency department when I'm practicing, every single time a medic unit from the jurisdiction where I practice sends an EKG, I have it in front of me. Now, a lot of times I think it's because they think there's something there, but we also get EKGs from triage at a rapid pace like a machine gun, and the reason that reaches us immediately is because they don't want our overreads to miss anything. So that's one of the things we're trying to practice, again, patient, a culture of patient safety.
You're muted, Roger.
That may be, anginal equivalents. And so what you're doing is making sure that you're not missing a significant finding in the absence of one that already exists.
Now, who is it that wrote that?
So Michael Kerr,
Oh, so is he explaining or is he asking a
I
question?
think he suggested that as a clarification.
Okay, so we have Mike. Oh, there it is. I'm sorry, it's just showing up with me. So I think Michael brings up a good point. I think he's trying to help me answer, and that is, as part of any assessment that you do, there's only so many things you're going to do before you make a decision, right? A clinical decision. There's only so many things you're going to do, and if the 10th out of 10 happens to be an EKG that you think is negative in your best estimate, based on your training to interpret one, you try to catch all the STEMIs, you try to read ones where you believe it's normal. And if it's one piece of the puzzle, we didn't want that to be considered in a way that would make you not want to acquire that piece of the puzzle to begin with. And so, by the way, the other thing about medical consult is if you call a doctor and say, can I let the patient go? And you paint the picture in any way, people can convince a doctor to think you're doing the right thing when maybe you didn't tell them. You're in control of what you tell the doctor. So doctors have been told that person sounds good for downgrade, and if they're not controlling the narrative, the online medical direction process may not be the saving grace. But what is a saving grace is not winging it, if that makes sense. And so thanks. I have a shout out from O'Neill Johnson that says, I haven't aged. What are you kidding me? Thank you, O'Neill.
All right. Well, I want to thank everyone for attending this evening. Definitely interesting, definitely pertinent to the times. It was a wonderful discussion. I thank Roger and Mario for coming tonight and presenting. It was very informative. I will say I do remember when your hair wasn't white, but mine wasn't either at that time. Oh my gosh.
For the audience at large, one of the things I like about Maryland is it's a small family and a big family at the same time of EMS, like EMS. And so I know why Dr. Sagel's address has Street Doc 465 in the prefix. And that's because I remember fondly Medic 465 being dispatched, either asking Carroll County to help it or being dispatched into Carroll County Mutual Aid all those years I was an EMT, Station 12 and Station 46 across the line used to run on. And I remember when he was Street Doc 465. And that's why it's in his email.
Very accurate.
Yes. So lo and behold, he
I also
becomes the
remember
chairman
taking
of
ATLS with you in the
Yeah.
80s.
Yes. We're showing our age, and I would say that my gray outdoes your gray, but it's just part of the it's part of the growing up in Maryland and staying in Maryland is years. Again, really honored to be around you all, and the Baltimore County, long live the Baltimore County Training Academy series, as well as long live Dr. Barinholtz's memory. And God bless you all. And you guys have a good rest of the evening. I'll stick around if there's anything else, but there you go.
Mario?
Yeah.
So
Hey, je suis heureuse de faire votre connaissance. Vous parlez français?
French. Oh, I don't speak the French.
Ah.
I speak the French.
Oui, enchanté de faire votre connaissance
je
aussi.
pensais, ben moi j'ai pensé, Roger, ce n'est pas un nom français.
C'est Roger, ça se prononce
Oh,
Roger.
Roger, oh,
Ça se
je
prononce Roger,
m'excuse.
et non, il n'y a pas beaucoup de Roger en France, mais il y a des Roger qui parlent français.
Ah bon,
Bon.
je comprends. Et moi, je m'appelle Pamela. Et ben, ça fait à peu près une vingtaine d'années que j'ai jamais amené quelqu'un qui parlait français.
So what she's saying is she's been bilingual
Sorry.
for a long time, but it's not often that she's in 20 years. It's very seldom to not at all that she's encountered an American bilingual person.
Well, or
We're out there.
even a French, it doesn't matter, but it's so nice to meet you.
It's nice to meet you too. And
Hi.
where do you ride? Where are you?
In that little county called Cecil, Tucky.
Oh, little county called Cecil. It's only our neighbors when I was in residency at Christiana running across
There
the
you
line
go.
and bringing me patients. 392 Elkton, they brought me
Oh,
patients.
there you go.
Oh,
There you go.
Absolutely. And
40
some
and
of the best
213.
clinicians in the state are running out of the system. And Christian Griffith has taken it over after his retirement. Yes, Maryland rocks all the way.
You guys are amazing, and it was really beneficial and such a blessing to have that information. Thank you.
No, it's so kind of you to say those kind words, and we're very happy to meet folks from all over the state. By the way, you go, your medical director rocks. She's a Christiana faculty, Morgan Castiglione, and ever since I met her and her husband, who's a Newcastle County medic, great people. Awesome.
Dr. Stone,
Absolutely. All righty.
Mario, put the checklist back up.
Yes. Let me go back to the checklist. I see a request to go back to the checklist. There you go, Paul.
I keep hearing my name.
Someone's calling from Mario. We're here as long as you want us.
That was me asking you to put the checklist up for a picture. I already got my picture, but somebody else wants one.
Sure. I see Paul asked for that. I'm happy to do it.
Yeah. And, I'll add one thing to what Dr. Stone said about Maryland being a small place. I got my start in EMS in 1999 when I took a first responder course taught by none other than the young paramedic, Benjamin Launer. And so it's amazing how small the world is. And I think Greg Ruff, who was
Hopefully he'll be a lecturer later on.
He's going to do it again because we know he's been speaking before, and I think he's aware we were here tonight. So yeah,
small world.
He got his invite last week.
Mm-hmm. Thank you all, really. Thank you.
Again, thank you so much for speaking tonight. It was very informative.
Thank you,
Right.
everyone who listened in. We really appreciate it.
We will be closing this week's episode.